Welcome to the deep dive. Today we're getting into something really important for our pets, specifically dogs and cats. It's called Patent Ductus Arteriosus, or PDA.
Yeah, PDA. And we've got some, well, pretty detailed source material here. Think clinical texts, research papers,
Hmm.
basically a thorough look at this particular heart defect puppies and kittens can be born with.
Right, and our goal here is to kind of sift through all that technical stuff and pull out what really matters.
Mm.
What is PDA? Why should you care? How do vets spot it? And crucially, what can be done? We want you to get the key takeaways.
Exactly. Get the core info without getting bogged down. And there's some pretty fascinating details in here.
Oh, absolutely. Like, I saw something about a heart murmur that sounds like machinery.
Yeah, that's the classic one. And another really strange sign. Potentially different colors between the front and back end of the animal.
Oh, okay. And the big one? A treatment that can apparently add something like a decade to a dog's life. That's huge.
It really is. Shows you how much veterinary medicine can do sometimes. It's quite amazing.
Definitely worth diving into. Okay, so let's start at the beginning. What exactly is PDA?
Okay, so fundamentally, it's an opening that stays open when it shouldn't. Specifically, the ductus arteriosus, which is a blood vessel, fails to close after birth.
Right, the ductus arteriosus. I remember that's like a normal fetal thing, isn't it? Connecting two big vessels before they're born.
Precisely. It connects the aorta, the big artery leaving the heart, to the pulmonary artery, which goes to the lungs. It's vital in the womb because the lungs aren't being used for breathing yet, so it bypasses them. But after birth, with the first breaths, it's meant to shut down, usually within days. If it stays open or patent, that's PDA.
Got it, a leftover connection. So what happens with the blood flow then if it stays open?
Well, in most cases, the pressure in the aorta is way higher than in the pulmonary artery, so blood naturally shunts or flows from the aorta into the pulmonary artery. That's called a left to right shunt. How much blood flows depends on how big that opening is.
Okay, left to right, high pressure to low, makes sense.
Yeah.
But the source material jumped pretty quickly to something else, something less common, but sounds, well, more severe.
Ah, yes. This is where it gets really complex. So, with that typical left to right shunt, if it's large, you get this huge volume of extra blood constantly pouring into the pulmonary artery and lungs. Over time, this can actually damage the lung blood vessels, causing the pressure inside the lungs to shoot way up. That's pulmonary hypertension.
Okay.
And if that lung pressure gets high enough, higher even than the aortic pressure, the blood flow through the ductus can actually reverse.
Reverse, you mean go from the pulmonary artery back into the aorta?
Exactly. That's the reversed PDA, sometimes called Eisenmenger's pathophysiology. Now you've got poorly oxygenated blood from the right side of the heart, which should be going only to the lungs, getting shunted back into the main body circulation via the aorta.
Wow. Okay, let me see if I get this. Left to right means too much blood going towards the lungs, causing a volume problem for the left heart. Right to left means low oxygen blood bypassing the lungs and going out to the body.
That's a perfect summary. The left to right leads to volume overload on the left heart, potentially causing congestive heart failure, or CHF. The right to left leads to low oxygen in the body, arterial desaturation, hypoxia, and the body reacts by making way too many red blood cells trying to compensate. That's called erythrocytosis, and it makes the blood really thick.
Okay, that paints a clearer picture of the two scenarios. So why is this so critical? What are the actual effects on the animal?
For the common left to right shunt, it's all about that volume overload. The left atrium and left ventricle have to handle all that extra blood coming back from the lungs. They enlarge, they stretch, and eventually they can fail, leading to fluid backing up into the lungs, left-sided CHF. How bad it gets really depends on the shunt size.
And the reversed right to left shunt.
That's a totally different set of problems. Not so much CHF from volume, but severe damage to the lung vessels, the high lung pressure, and critically low oxygen levels. These animals are hypoxic, struggling for oxygen, and they face complications from that super thick blood-like clots, poor circulation, that sort of thing.
So it hits the heart and lungs primarily, but the right to left also messes with the blood itself.
Exactly right. Cardiovascular system is obviously involved.
Yeah.
Respiratory system too, coughing, breathing, issues from fluid buildup in LR, or just the high pressure and low oxygen in RL. And yeah, the hemic system, the blood, gets directly impacted with erythrocytosis in those RL cases.
Now, who gets this? Is it common? Are certain pets more likely to have PDA?
It happens in both dogs and cats, but honestly, it's way, way more common in dogs. The source calls it one of the most common congenital heart defects in dogs. They estimate maybe up to 2.5 cases for every 1,000 live births. Pretty rare in cats, though.
2.5 per thousand. Yeah, that's significant. Is there a genetic link?
Oh, absolutely. Definitely. In many dog breeds, it's known to be inherited. They think it's a polygenic thing, meaning multiple genes are involved, not just one single faulty gene.
For specific breeds mentioned in the source?
Yeah, quite a few, actually. Lots of popular breeds. Let's see. Bichon Frise, Cavalier King Charles Spaniels, Chihuahuas, Cockers, Collies, Springer Spaniels, German Shepherds, Labs, Maltese, miniature and toy poodles, Pomeranians, Shelties. It's a long list.
Wow. Yeah, that covers a lot of common pets.
Yeah.
Important for owners of those breeds to know. What about male versus female?
Females, yeah. The source notes females seem to be predisposed in many of the affected dog breeds.
And when does it usually get picked up? Do they show signs right away?
Often they don't. A lot of puppies seem perfectly fine initially. The vast majority actually get diagnosed during their first puppy checkups and vaccinations. The vet listens to the heart and hears that characteristic murmur.
Ah, okay. So the vet finds it before the owner notices anything.
Very often, yes. Now, if signs of CHF do develop from a left to right shunt, that could be weeks, months, or even years down the line. For the right to left shunt, the actual flow reversal can happen pretty suddenly, often when they're young, like under 4 months. But the signs might not be obvious until later, sometimes even years later in dogs over 5.
So early detection at the vet is key. But signs could pop up later. What would an owner see? Or what else does the vet find on the exam?
Okay, if it's left to right, heading towards CHF, the owner might notice coughing, maybe some difficulty breathing, the pet getting tired really easily during play, or maybe just not growing as well as litter mates.
And for the right to left, different signs.
Totally different, because the problem is oxygen and thick blood, not fluid backup. So you might see weakness, especially in the back legs, that gets worse with any exertion. And because of the thick blood, really serious things can happen, like seizures or even sudden death, maybe from a clot.
Right. The signs really track with the underlying blood flow problem.
Mm-hmm.
What about that classic exam finding you mentioned earlier, the machinery sound?
Yes. That's the big clue for the typical left to right PDA. It's this continuous machinery type murmur. Vets listen over the chest, sort of high up on the left side near the base of the heart, over the pulmonary artery area. It sounds like, well, like a washing machine humming away, constantly, through both the heart squeezing and relaxing phases.
Machinery murmur. Yeah, I can imagine that's pretty unmistakable for a vet.
It really is very distinctive. Although the source does say in really tiny puppies or in cats, it might not sound quite so perfectly continuous, maybe more like a long whoosh that covers most of the heartbeat. If it's loud, you might even feel it buzzing on the chest wall. It's called a thrill.
What else might the vet pick up with a left to right shunt?
Often the pulses in the legs feel really strong, kind of bounding. They call them water hammer pulses. Listening might reveal signs the left heart is enlarged. And if CHF is starting, you'd hear faster breathing, maybe crackles in the lungs from the fluid. Sometimes, especially in bigger dogs with really enlarged hearts, an irregular heart rhythm called atrial fibrillation or AFib can develop.
Okay, classic murmur, strong pulses, maybe breathing changes. Now, what about the exam for the right to left shunt? You said no continuous murmur there.
Right, completely different findings. No continuous murmur, pulses feel normal. Instead of the left side feeling enlarged, the right side might feel more prominent when the vet feels the chest. You might hear a different kind of murmur, maybe just during the heartbeat squeeze, or the heart sounds themselves might sound abnormal, like split. And then there's that really striking visual cue.
The different colored pause thing.
Exactly. Differential cyanosis, this is the classic sign of an uncomplicated right-to-left PDA. Because the low oxygen blood from the PDA dumps into the aorta after the arteries supplying the head and front legs branch off, the back half of the body gets less oxygen.
So
you look at the gums, inside the lips they're pink, getting good oxygen, but then you look at the back end, maybe inside the vulva or rectum, or sometimes even the nail beds or skin of the back paws if it's bad, and they look bluish, cyanotic, pink in the front, blue in the back.
wow, that is incredibly specific. Pink gums, blue paws. Yeah, that would definitely catch your eye.
It's a major red flag. Though it's worth noting, the source says if the erythrocytosis is super severe, or if there are other heart problems going on, even the front end might look a bit bluish too.
Okay, so the physical exam gives huge clues. How do vets absolutely confirm it's PDA and tell the difference between the two types?
Yeah, the exam raises suspicion. They'll think about other things that cause murmurs too, of course. But that machinery murmur is almost diagnostic for LR PDA. For the RL kind, with the rear limb weakness, sometimes apparently it gets mistaken for nerve or muscle problems initially, like myasthenia gravis.
What about tests, like blood tests or imaging?
Routine blood work, usually totally normal in the standard left-to-right cases, but in the right-to-left shunts, that's where you see the erythrocytosis, that packed cell volume. The measure of red blood cells will be sky high, like 60, 70, even 80% sometimes.
With imaging?
Imaging is really the key. X-rays can give hints. They might show the heart looks big on the left side, or the lung vessels look overloaded in LR cases, or maybe the right side looks big and you see this little bulge on the aorta called a ductus bump in RL cases. But echocardiography, the heart ultrasound, that's the gold standard.
The echo, right.
Exactly. It lets the cardiologist actually see the heart chambers, see the pulmonary artery, see the aorta, and critically, using Doppler, which shows blood flow.
Ah, they can see the shunt itself.
Precisely. They can see that continuous jet of blood flowing across the ductus in a left-to-right PDA, or in a right-to-left, they can see the flow going the wrong way or maybe swirling back and forth. They can also measure pressures to assess that pulmonary hypertension.
So the echo nails the diagnosis and tells you which kind it is.
It really does. It's the definitive test. Things like angiography, injecting dye, that's not really routine for diagnosis anymore, more for complex cases or maybe during a closure procedure. And ECGs, heart tracings, they're mostly useful if there's a rhythm issue like that AFib we mentioned.
Okay. We've got what it is, why it's bad, who gets it, what it looks like, how vets diagnose it. Now, the hopeful part, what can actually be done?
And this is where it gets really encouraging, especially for that common left-to-right type. The key word from the source is intervention. If an animal shows up in CHF, you stabilize them first, of course, diuretics for the fluid, maybe oxygen, but then the recommendation is promptly close that PDA.
Promptly, meaning don't wait even if they're just a puppy.
Exactly. The source is really emphatic. Don't delay closure. Even in stable puppies that seem fine, maybe just found on that first checkup, even as young as 7 or 8 weeks old, closing it early gives the best possible long-term outcome.
How do they close it? Surgery.
There are 2 main ways. The traditional way is surgery, open chest surgery, called a thoracotomy, usually on the left side. The surgeon goes in, finds the ductus, and ties it shut with sutures. Ligation, it's called.
Okay. And the other way?
The other way, which is becoming much more common, is minimally invasive using catheters.
Catheters, how does that work?
Yeah, they insert a catheter, usually into a big vein in the leg, and guide it up through the blood vessels into the heart and right to the ductus. Then, through the catheter, they deploy a small device, could be metal coils, or a special plug called an occluder right inside the ductus to block the blood flow.
Wow, so no big chest surgery.
Right. It avoids the thoracotomy. There used to be limitations, like really tiny patients, say under 2.5 kilos, might have been too small for the devices, but they're developing smaller and smaller devices all the time now.
How well do these methods work? Are they risky?
You know, in experienced hands, both surgery and the device closure are very successful with really low mortality rates, like under 3% for surgery, maybe even lower for the devices. Now, complications can happen with either bleeding with surgery or sometimes with devices the closure might not be 100% complete the first time, or rarely a device could move. But overall, the success rate for actually closing the PDA is very high.
That sounds fantastic for the left to right ones.
Yeah.
But what about the right to left kind? The ones with the high lung pressure? Can you just plug those up too?
Okay, this is probably the single most critical takeaway regarding treatment.
Yeah.
You never, ever close a right to left PDA.
Never. Why not? It's still an abnormal opening, isn't it?
It is, but think about why the flow reversed. It's because the pressure in the lungs is dangerously high. The right ventricle is straining to pump blood into those high-pressure lungs. In that situation, the open ductus, connecting to the lower pressure aorta, acts like a safety valve, a pop-off valve. It gives the right ventricle an escape route for some of that pressure.
Oh.
If you suddenly close that escape route, the right ventricle has nowhere to send the blood except slamming it into those already hypertensive lungs. The pressure overload would be immediate and catastrophic. It would likely cause acute right heart failure, and the animal could die very quickly.
Wow. Okay, so the thing causing the long-term problem is actually acting as a short-term lifesaver for the right heart in those specific cases. That's a huge difference.
It's a profound physiological difference. So for right-to-left PDA, management is purely medical. You can't fix the underlying problem, so you manage the consequences, primarily that thick blood, the erythrocytosis.
How do you manage that?
Keep them really well hydrated. That helps thin the blood a bit. And then often, periodic phlebotomy is needed. That means carefully removing a calculated amount of blood on a regular basis to keep that red cell count, the PCV, from getting dangerously high. Usually they aim to keep it under about 65%. Sometimes drugs like hydroxyurea are used if phlebotomy isn't enough, but that's less common. And some drugs like sildenafil might help with the pulmonary hypertension symptoms in some dogs.
What about medical options for the left-to-right cases if they have CHF and surgery isn't immediate?
Right, if closure has to wait or maybe isn't possible for some reason, then you treat the CHF medically. That usually means diuretics like furosemide to get fluid off the lungs, maybe ACE inhibitors like enalapril, and often pimobendin, which helps the heart pump better and relaxes blood vessels. If they have that atrial fibrillation rhythm, you'd use drugs like digoxin or diltiazem to control the heart rate.
Okay, so what's the outlook then? The prognosis?
Well, some dogs with really tiny left-to-right shunts might actually live a normal life without ever showing signs, but that's probably the exception if the shunt is significant.
But for the ones that get closed, you mentioned that incredible lifespan increase.
Yes. This is probably the most striking statistic in the source material. For dogs with the typical left-to-right PDA, if it's closed successfully, especially before they develop moderate or severe CHF, the prognosis is excellent. And get this, closure adds an estimated 10 years to their median lifespan.
10 years. That's basically a whole dog lifetime for many breeds.
It's incredible, isn't it? The comparison is stark. Median survival with closure is around 12 years versus only about 2 years without closure. The source says something like 50–60% of dogs with untreated LRPDA will die from CHF within a year of diagnosis. So treatment is truly life-saving. Now, the prognosis isn't quite as good if they already have severe CHF or AFib when they finally get it closed, but it's still much better than no closure.
And the outlook for the right-to-left cases, the ones you can't close.
That's definitely more guarded. They can sometimes live for several years with that careful medical management, the phlebotomy and hydration. But sudden death is a real risk, often related to clots or other complications from the thick blood and low oxygen. The source mentions some breeds, like cockers, might be better and sometimes live past 5 years, but it's much less predictable than a closed LRPDA. Cats are also variable, sometimes progressing fast.
Are there complications to watch out for even after a successful closure?
Well, like any procedure, there are risks. Perioperative risks like bleeding or infection exist. With devices, there's a small chance of incomplete closure needing a second go, or the device could potentially move, though that's rare with modern devices and techniques. Very rarely, the surgery itself could cause some narrowing near where the ductus was. And if there was already significant heart or lung damage before closure, some issues like arrhythmias or mild pulmonary hypertension might persist or develop later.
So follow-up care is still needed.
Yes, definitely monitoring right after the procedure, checking breathing, vital signs, and listening carefully to make sure that continuous murmur is gone. If the murmur persists, that needs immediate reinvestigation, usually with another echo, to see if the closure is incomplete. But interestingly, the source suggests that for routine, uncomplicated closures where the murmur disappears completely, yearly cardiac checkups aren't necessarily required long-term.
And prevention, with that strong genetic link.
Pretty straightforward advice based on the genetics. Don't breed affected animals. Since it's clearly heritable in so many breeds, breeding dogs or cats diagnosed with PDA would just perpetuate the problem.
Makes total sense. Wow. Okay, so we've really covered a lot of ground here on PDA. We started with it being basically a fetal blood vessel that forgets to close,
leading to either the common left-to-right shunt causing heart overload and CHF, or that less common but much trickier right-to-left shunt with high lung pressure, low oxygen, and thick blood.
We talked about who gets it, lots of common dog breeds, especially females, and how it's often found super early, thankfully, on those first vet checks because of that murmur.
Right, that classic continuous machinery murmur for the LR type, or the completely different picture for RL with the rear leg weakness, and that really strange differential cyanosis pink front blue back.
And how echocardiography, the heart ultrasound, is really the definitive diagnostic tool, letting vets see the flow and confirm what's going on.
And then the treatment, the huge success story for LRPDA with prompt closure, either surgery or catheter devices, giving an excellent prognosis and potentially that extra decade of life.
While also understanding that absolutely critical point. You never close a right-to-left PDA because that opening is acting as a necessary pressure relief valve. Management there is medical. Focus on the blood thickness.
Yeah, the prognosis difference is just night and day, guarded without intervention for most, but potentially a completely normal life after successful LR closure. It's really quite remarkable.
It absolutely is. And, understanding this really hammers home the value of those routine vet visits, especially for puppies. Catching that murmur early before the heart gets overwhelmed, that's what makes such a massive difference in outcome. It's a great reminder for all of us to be diligent about checkups,
Yeah.
especially if you have one of those predisposed breeds.
Early detection and intervention are everything here, truly.
Which leaves us with maybe a final thought for you to chew on. Knowing there's such a strong genetic link for PDA in so many popular beloved dog breeds, how does understanding a condition like this make us think about responsible breeding? About the health legacies we're creating for these animals we love so much, definitely something worth pondering.